I have been involved for the last 4 years with an effort within the state of New York to disseminate cognitive behavioral treatments and other effective modalities of treating youth with a range of disorders. We've done trauma-focused CBT, we did treatment for adolescents with depression, parent management training, disruptive behavior disorders. And one of the things that became apparent over time is that it's important not just to give a workshop on here's the how-tos for this manual or this approach, but to also, step back and at the beginning of the training, we give the fundamentals, the principles of what underlies the treatments. And while I probably am going to be repeating a lot of stuff in this first hour for you all, there are therapists who are naive to this. For some, it may be a completely different modality than what they're used to. So we're going to go through some of this because these are the underlying guiding principles and theory that is behind every and any cognitive behavioral treatment approach. This 1-hour presentation is going to be on social learning theory, the basics of what underlies cognitive behavioral therapy for the range of issues, problems, disorders that may present in a clinical setting. And we're going to focus on children because that's what we want to do with this particular dissemination effort, but these principles apply to adults too. And if you happen to watch The Dog Whisperer, you'll also see that they work there, as well as with Super Nanny. So I love Super Nanny. You should hear what her workshop fees are. They're not like mine, that's for sure. Wow. So the cognitive behavioral approach, which is going to be the basis of most of the treatments that are presented in this effort, this is an interactionist perspective where the internal and external environment are constantly at play within an individual in shaping one another and shaping responses that occur in the course of the day, in the course of a week, and over time. And over time, shaping responses in such a way that some consistency occurs. What we might call personality may be a culmination of learning experiences that have been shaped to such that a child reacts in certain ways with frequency and with predictability, given frustration, given certain kinds of reinforcements or attention. So this is the basic underlying principles that we're going to go through. The emphasis on cognitive behavioral approaches, as opposed to more traditional theoretical models, like the Freudian model, is that there are learning processes that are interacting with the organism or the person as they are growing and developing. And these learning processes involve environmental contingencies, the way the environment is responding to and reacting to the person, and also what that child is viewing and experiencing. So a lot of modeling. They're picking things up. It doesn't have to be directly, but they're picking things up from what they see in the environment. Very interesting. Let me give you just a little example of something. I had a 6-year-old child who came into my clinic who was so adorable, this little girl, who had a severe phobia of costumed characters. Now, you would think, all right, so what's the big deal? Just don't take her to Disney World. But in fact, you couldn't take her anywhere. Her parents could not take her to parties, because what do parents do these days? They get a clown to come in or something. Halloween costumes hanging in a store window, these things were frightening to her to no end. And it was so severe that the mother had to find out and had to work it out with the school that if there was anyone who was going to have face paint on or anything like that, she had to know so she could pick the child up. The parents tried to have somebody sit in front of the child and go from being plain to putting a costume and face paint and everything on. As soon as that was occurring, her anxiety hit and she would start panicking and crying. So all of these things were going around this child over time. She was so severe. She's sitting in my office then, and here's an interesting thing. What children pick up from what they watch and just hear around them. Both of her parents were veterinarians. And she had been in and around them in their work. A 6-year-old child sits in the chair in front of me and says, "Dr. Albano, isn't there a medicine you could give me for this? My parents give dogs and cats all kinds of medicines to make them better." That's modeling. No one told her about medications for any kind of things in a person, psychological issues. But just absorbing what's in the environment, you never know what kids are going to pick up. Actually, parents are quite surprised when they hear some of these things. So interesting that modeling can occur without any direct interaction with something happening, just observing and listening. And we know from working with families that parent-child interaction is a big one because they're shaping one another. It's always a big question, the chicken or the egg. Was the child anxious first? Was there parent anxiety that, interacted with a substrate that allowed for child anxiety? What were the parenting practices at baseline before the anxious child showed up? Did they shape the parent? Did the parent shape the child? It goes back and forth. And actually, when you look at externalizing disorders, parent-child interaction therapy is based exactly on these principles of changing the interactions of the families, teaching the parents new ways of relating to the child so that it helps the child bring under control their externalizing oppositional behaviors and such. So very much based right on social learning theory. I want to just dispel some myths about cognitive behavior therapy. Oh my gosh, the myths about it. We hand out M&Ms all the time and that's about what we do. If only, right? That would be so simple. Cognitive behavior therapy, one of the myths is that it's very mechanistic and that all clinical procedures are really just stimulus, response. In fact, you can't do good therapy without there being a real interpersonal context, an alliance with the patient, and attention to the interactions between the therapist and the parties, be it the parents, the children, both. It is not a mechanistic just respond to what the patient is presenting and reinforce this and extinguish that. It is all the good stuff that we have known about from the time of Carl Rogers and others. You have to bring empathy, warmth, genuineness, right? Positive regard, all needs to be right there with you when you're working in a CBT frame. So that's one thing. The second that we get hit with all the time, and I practice in New York. It is like the psychodynamic capital of the world. Oh my goodness. Whoa. But I have great relationships with my colleagues in psychodynamic therapy in the city and get teased by a couple of them about the myth of superficiality. In fact, the internal life of the patient is very important to the process and the procedures of CBT and the development over time of where CBT goes with the patient. So paying attention to the dreams, the desires, the beliefs, the history of the patient, all of these things are quite important, and it's not just focused on a goal to the exclusion of all this. It's very much a part of what has to be understood and a part of the conceptualization as you work with your patient to understand what you're going to put together with them in working and how things are going to change over time as different things go on in their life. Ahistorical is another thing. We don't care about the past. We're here and now, just the here and now. Well, let me illustrate from an adult patient that I worked with that right after 9/11, I had a patient a couple of months later show up for therapy, a man who was in his 60s, who did international business. And he used to fly quite often back and forth to Europe, and he couldn't fly anymore. Now, the interesting thing was he had been in long-term psychodynamic therapy. And the origin or the issue with him flying was that he was afraid that while on the plane, he would get very upset lose control, and act out in such a way as to be arrested, taken off by air traffic control people and all this other stuff. And because, post 9/11, you act odd on an airplane, they're doing something about it. But this was long-standing for him. The issue after 9/11 was that what he used to do to deal with these airplane rides he had to take all the time was Xanax plus scotch. So he would get on a plane with his Xanax, got him on the plane, and as soon as he got on the plane, down went the scotch before they even shut the door because he was first class, and you get a drink as soon as you get on, and he would knock himself out for the trip. Wake up in Zurich or wherever he woke up. But he was anxious now, again, on top of the already agoraphobic anxiety, he was anxious about losing control now in a different way. What if the drug and the medication and the drinking interacts? Now, the interesting thing, as I say, our work is in the here and now, absolutely, on how to deal with that anxiety and also how to deal with taking flights without needing to knock yourself out. But the important thing was, where did this come from? And he knew this for 30-something years from his former therapies. He used to be locked into a closet when he was 4, 5, 6, 7 years of age by his mother, he and his brother, separate closets, he under a stairwell and the brother in another place whenever they were acting up. So we knew the origins of the fear. And it's very important to understand the origins of those fears, because what we brought to the present then in working in the here and now with him is that mama's long gone. Those situations are long gone. What have you learned about yourself? How you're managing it now is not what you need to do to manage that now. So we worked with some trauma-focused CBT approach about the past, while at the same time doing exposures in the present. And this is why I like New York. Those subways are great places for exposures. Especially when I had him go down in the subway with me, get on a car that was very crowded, and start singing God Bless America. Okay? You can act up on a New York City subway, and nobody is going to even look up from their book at you. So anyway, simplistic. This is the other thing that we get hit at, is that CBT is overly simplistic. You're just, sort of taking care of a symptom and everything's done. And in fact, that's not the case either. CBT calls for very deep understanding of psychopathology, of people, development across the ages, and then also a deep understanding of the principles and the procedures that underline CBT, so you can put these together in a formulation that makes sense and works with your patient and can be flexible where it needs to be for the patient. So just wanted to get these out on the table, some myths to dispel about cognitive behavioral therapy. The principles we're going to go under now are mainly social learning and the reinforcement principles, but then again, also the principles from basic psychotherapy is important. Assess and formulate are very important for the conceptualization of the way you're going to work with any patient that presents to you, so you need to do a good assessment. And the cornerstone of cognitive behavioral therapy is assessment. You assess in the beginning as you're meeting the patient, and actually the assessments start with the phone call. I work in the anxiety disorders predominantly. Very interesting phone call from a parent once for her daughter who was 12 and had school refusal and separation anxiety. Went through a phone screen with her, an intake, set up the time to meet the daughter and start getting things rolling with the daughter. And the mom says to me at the end of the phone call, "My sister will bring her. I have agoraphobia. I don't leave the house." So assessment is very important, especially with children at the phone call. And I also do we do assessment just watching what happens in our waiting rooms with families. But assessment is important. It begins with your first contact with the patient. And then with CBT, of course, we're going to formalize the assessment as we hone in through whatever intake procedures you have and whatever initial session procedures you have at diagnosing and identifying problem areas, we're going to hone in on certain things that are priority to the patient and the parents to work on, given their interference in the functioning of the child or whatever it might be. And we are going to take measurement of those issues as we go through therapy. In very simple ways, some of them, we'll talk about them in most of the workshops that are going on. We'll give you different types of assessment methods, taking ratings of depression or mood, taking ratings or counting number of activities a socially anxious child engages in with other people during the week. There's all different simple assessment methods that you use to address the goals as you're moving along. And that helps in working with your formulation and reformulating your formulation of the patient as treatment progresses. Observable and measurable goals are important, so I don't want to just, you can't say, the patient can't just say, my goal is to be happy. Or my goal is not to have anxiety. But they really have to be observable, measurable things that we are defined in terms of actions and the behaviors, as well as then also what they can relate in terms of their mood and the way that things change for them, in the way they think, and the way that they present themselves over time to people and in situations and manage situations. With our guiding principles, we always present to the families our understanding of what they are coming in with, the model of CBT, how it is going to help you with this issue, or what it's designed to help in terms of the issues. And within that, the education that goes along with that gives them corrective information about what it is that they are coming in concerned with. And it is amazing. I spent 5 years after I finished my internship in psychology working at a highly specialized program that was run for the anxiety disorders, run by a Dr. David Barlow, who's a preeminent psychologist and clinical scientist in the field. He has pioneered the treatments of anxiety disorders. He is the psychologist, I would say, he and Tom Borkovic, who really have pioneered treatments of anxiety disorders in adults and children. And working with him is where I really learned and saw firsthand what happens when patients in their first session or two are presented with a coherent model and understanding of their issue and what is meant to be done with the CBT to help them. And I can't tell you in those 5 years how many people cry with this information and thank the therapist because they've never been told and it's never been explained to them in such a way. And also, what's so important here is the installation of hope to manage and change a situation to a degree that relieves them of some suffering. So I think the psychoeducation portion and presenting the model, is really critical. And I've had so many patients. One that comes to mind specifically was a 16-year-old girl who had a blood phobia. Blood phobia is where you faint at the sight of blood. It's actually it runs in families. It's highly familial in its transmission and aggregation. And what happened, this young girl was top of her class in high school, editor of the school paper, very well liked. In 8th grade, she had been to a movie that showed bloody, gory scenes, and she fainted. And from that point, now we got her junior year of high school, from that point, the fainting began and generalized, not just at the sight of blood, but even she was sitting in class one day, and someone behind her said to another kid, "Cut it out," and she went out. So the school principal told the parent, enough already. She was fainting like 3 times a week on average. And the principal told the parent, get her out until she stops this attention seeking. So we had a huge sign on the building in Albany phobia and anxiety disorders clinic. And the parent, like she said, I literally was driving down the street, didn't realize, there it was, boom, I pulled in. When we told this family, it's interesting, some physician had told her, someone who they had consulted had told them it was so severe, this kid's blood phobia, she'd never be able to have children. Now imagine saying that to a mother and her 16-year-old daughter. So when we assessed the situation, understood it's blood phobia, and we have a way of treating it. Treating the vasovagal response that occurs, understanding it, and treating it in such a way that we could prevent it from happening again and have her be aware and understand this mechanism and then how to keep herself from fainting. Both of them were crying and so relieved. And within about 8 sessions, she was fine. She was doing very well. So this is a very powerful thing, and I'm not saying this is just for CBT, but it's where therapists help patients really understand the issues and lay it out in a way that's really clear for them, and then make sense of what the treatment is going to be like in terms of addressing the goals of getting over this. It's so helpful to them.
So was the mother treated as well?
Well, it was the father. Yeah, it was the dad. And he was in a position that he wasn't home a lot. So we didn't treat him, but the teenager did very, very well. He was not in the house. He was a merchant marine, so he wasn't around a lot, unfortunately. But it was a very interesting thing. I mean, the mother, though, what we did with her, which we'll talk some about this afternoon in the way that we work with parents, is we got her to stop doing the things that overprotected the child and festered the anxiety, which this was happening around the time of, I think, the first Gulf War or one of the earlier things during Bush 1. And I think what happened is the mother would not bring magazines into the house that had pictures from the war. She would screen, she wouldn't show, she put red meat into brown paper bags in her refrigerator so they couldn't be seen by the daughter. Things like that. So we had to change all that kind of thing. And that's where the treatment with the family was, because the father was not as active in the treatment and around.
I find it unusual that you can inherit a specific
Well, it's the sensitivity that is the biological sensitivity to the vasovagal response. It's a physiological reaction. The vasovagal response is a physiological reaction where your blood, and you have felt this. It's where your blood pressure starts to rise quickly, so you're tensing up, and then suddenly it bottoms out on you. And you know the fuzziness that you get, and then you go cold, and then you're out when you're going to faint? It happens very quickly. And that is, so biologically, she probably, and in families where this runs, they probably have more of a tendency towards that. And then over time with the conditioning experiences, they're keeping that at bay in such a way, not learning how to manage that. All right? So the other thing I will say is research is me search. I had that. And having to treat people with this phobia helped me get over mine, which was interesting. So the other thing in terms of principles, home-based monitoring, experiments and exposure, all of these kinds of things that we do with our patients, which are very active ways of getting data all the time from them and helping them to focus on their concerns. All of this helps to facilitate the therapy process, but also their insight into what's going on, and then give them motivation for change. Yes?
I find it fascinating because I know someone that has fainted in his wife's labor, and I never knew about this before. But
OBGYNs are my biggest source of referral, and it's the dads, the new dad-to-be. Yeah. And it's like, fix them because I don't want them in my delivery room, is what the docs say.
I'm thinking of his children now, just because they inherit the sensitivity, if there's not the conditioning or the...
Well, remember something, with transmission, it's not a guarantee it'll happen.
Right.
But you do, for any kind of vulnerability that may exist, even where there's been grandma or grandpa who's had a depression and things like that, you want to be sensitive to, you want to be aware of these things. I mean, for instance, in teenagers who come from families where there's substance abuse in some of the relatives. I do a lot of work with them about education, why you are more at risk than maybe the average kid. And so why it's really important for you to be careful and to make healthy choices for yourself at parties and as you move on. So, different things do have a higher loading than others in terms of vulnerabilities. And this afternoon, we're going to talk about that model more in terms of especially family environment and how the family environment needs to be addressed, especially when there's these bigger vulnerabilities. Okay? So moving along, the main thing, and well, maybe that leads right into this, learning occurs in a social context. So learning is occurring from the moment that child is brought into the world by all that's around it and surrounds it. It can occur by observing others. And the main thing is that the cognitive processes, thinking can influence learning. Now, this is the big thing. When, at the beginning of time for psychology and psychiatry, there was Freud, and pretty much there was Watson. And Freud's theories were developed by observing families. When you think about it, and observing children and families, and looking at the roots of psychopathology in adulthood as being and occurring and being set very early in life. And when Watson did his classic experiments on where phobias come from, he demonstrated that early on, children can observe or be exposed to things that can condition fears and phobias, and the whole conditioning model occurred and moved along. Now, over time, what happened with the behavioral model is it stayed pretty behavioral in terms of external reinforcers operating on the organism, and the organism responds. But in the 50s, Aaron Beck and Albert Ellis started to develop cognitive models of conditioning and psychopathology within the cognitive frame. And both of them actually had been psychoanalytically trained, but they both attended to and understood that as their patients were coming in one after the other, they seemed to be presenting with very similar, one after the other, errors in thinking or distortions in thinking. So Beck came up with automatic thoughts and errors in thinking, whereas Ellis called these irrational beliefs. And these are things like, I must be perfect all the time, I must be loved by everyone. And that these ideas were shaping the way that the patient interacted in the world and behaved. So the behavioral and the cognitive were sort of running next to one another, with the hardcore behaviorist saying, you don't go in there, that's mentalistic stuff, and you can't observe it. And the cognitive people say, we absolutely can make it observable, and we can make it observable by asking the patient, and then also make it observable by giving them questionnaires and ways of writing down what they're saying. And it was Albert Bandura who, in the 60s, developed this social learning approach, really that brought the two together to demonstrate that interactions with the environment shape behavior, and behavior is thinking as well as acting. And they're all interacting with one another. So he brought us all together. Thank goodness. It was like the Union, finally the South and North have met again, and we've come together as a united cognitive behavioral approach. And that's where we've been ever since. The fundamental concepts that underline working in a CBT approach is understanding, though, these reinforcement models that Watson and then Skinner developed, and really Skinner pushed. A stimulus is something that's going to influence the occurrence of behavior. And we know this. Walk into your house with a big bag of Ben & Jerry's, and with it, how long does it take for your kids to be at your kitchen table saying, me, me, me? So a stimulus is going to influence the occurrence of a behavior. The response is the result of applying a stimulus. Reinforcement is the act of following a response with a reinforcer. This is where we really have the work cut out for us with parents. Okay, I'm going to get ahead of myself with one of my analogies. I love this one, though. And I'm just going to give you a little bit of it, and we'll work on, I'll wave it in later, too. I got a call from a dad one morning, I got matched up with this family. They were referred to me by a psychiatrist friend because they were Italian. Okay. I don't think I'm the only Italian psychologist I have to say, for the sake of my mother, because if she ever sees this on the web, she's going to come after me, I'm half Irish. Okay, so anyway, I get this call from this dad. It just so happens I was at Ellis Island this morning, that particular morning, with my niece and nephew from Minnesota, and he calls, I answer the phone, hello, he goes, "Doctor, I'm going to kill my kid." Like, okay, hold on. I'm going to kill him. Like, take it easy, hold on. I send my niece and nephew with quarters to look at the Statue of Liberty through the little thing, the binoculars. What's up? Let me put my wife on the phone. He puts his wife on the phone, and he starts telling me, last night, we were at Circuit City. I have a 10-year-old son I was seeing with ADHD. And he said to me, "Daddy, please get me the Xbox. If you get me the Xbox, I'll be good. I promise, I promise." Here we are the next morning. They needed to go to Grandma's for something, and the child had been on the Xbox since about 5 a.m. and wouldn't get off it. So we're going to talk about reinforcement and how you use reinforcement. Because at this point, what did Dad do? He put the cart before the horse, didn't he? All right? So we're going to talk about that. A reinforcer strengthens the probability that the behavior is going to occur again. In this case, oh boy, they had it all backwards. Extinction is where a response is no longer going to occur because we stop giving the reinforcer. And whether it's attention to a tantruming child or overprotection, comfort to the anxious child, things like that, we've got to modify, especially with younger children, parental behaviors. We also have to work with adolescents and parents on contingencies and how these things are delivered in such a way that the behavior they want and the behavior that's helpful to the child really gets shaped, and not that they're constantly there. Hey, this is where I do send families to Super Nanny, because she really knows how to use extinction and to take attention away from negative behaviors. It's a very important thing. And then shaping behaviors over time. You can't say to a 10-year-old child, go up to your room, clean it all up, and eat that dinner, and then you come downstairs, and you better be in your pajamas, and we're going to be ready. Oh, my goodness. That's like too much to handle at once. It's like, fixing the deficit. You can't do it all at once. So we have to successively shape one thing at a time until, they can put the package together. Considerations in child therapy. There are outside influence as well as internal influences and risk factors that are at play, biological and psychological vulnerabilities that are brought to the table because they're humans. They're living beings. And again, the environment is going to interact with this. And all of this is happening in a developmental substrate. And so there's going to be things within the child that might set limits on what you can do or how you can do things. Cognitive developmental issues, developmental disorders and such. There will be situations and there will be issues, physical limitations and things that you have to work with and adapt your therapies in such a way to build strengths that can compensate as best as you can for some of the limits that nature maybe has put on the child. And then the other thing, of course, we understand too, is there's going to be contextual issues, family issues, and environmental issues that are at play that are going to influence everybody, and how treatment is received, to help to change a situation that has brought the family to therapy. So there's something going on that's not sitting well with everyone, and maybe they were told to come by the school, or maybe they were told to come by a pediatrician, or by a court system, or by others in the family who say enough is enough. We're not inviting you back here if the child is going to be acting in the way they're acting. Something's brought them to your office, and we have to look at the context and what that is, and recognize that sometimes even the parents are coming in unwillingly, and there's a lot of stuff to work with there, right? So all of this has to go on. That's Christopher, my nephew. Is he cute? So cute. Tonight, I can't wait to see him tomorrow. I'm going to play with him all day. Many behaviors can be observed by watching others. I mean, can we think of anything that doesn't transmit by modeling? Anger does. That was Bandura's original study with the children observing the Bobo doll and those who were given attention for hitting the doll or watching the person who was hitting the doll, they hit the doll. Those who were not given attention while somebody was aggressing on the doll, they did not aggress on the doll. So fear reactions, aggression, altruism, moral behavior, academic tasks and how you go after it, all these kinds of things are transmitted to some degree through modeling, all right? Kids will pick them up. The list goes on and on. But there has to be some necessary conditions for modeling to really take hold. And this is something that doesn't just happen in a vacuum. You can't just sit your child. Imagine if we could just make the kids the way we want to be. Just sit them in front of a videotape, like, what is it, Clockwork Orange, and just let them watch again and again. Okay, they're going to come out and be the perfect little children. Nope, doesn't happen. The person has to pay attention to the model. And this is why in child therapy, we oftentimes go to what's called peer pairing, where we try to find models with the children who are around their age or younger than us old therapists. And so and this is in schools. I will often, for a very socially anxious young child, I will ask the teacher to have that child paired up with activities and things with one of the even-keeled, middle-of-the-road kids, not the popular ones. They're too frightening. And, not the rambunctious ones. They may be overwhelming. But the even middle-of-the-road kids. Peer pairing in its different ways is where the model is more similar, so you can identify with them. And also, if you can set it up in a social context in terms of the modeling, you get, much more interest on the part of the child who needs to learn something in following the model. So, and this is one of the bases, I think, for the summer treatment program here at Florida International University that Bill Pelham developed many, many years ago and is disseminated around the country. The patient, the client, must be able to remember what is being observed. So repetition and rehearsal is very important. Yes?
Have you heard that there's like a new movement towards middle school students doing, and elementary doing like peer mentoring almost?
Well, peer mentoring is wonderful when it's well supervised and we have a lot of programs like that in New York City.
Is there any research on it? Like, has it shown to be more successful or changing the behavior?
There is research on it. I can't quote it directly, but there's even a big research community in the mentoring issue, just in and of itself. And so there's research in anxiety, for example, that shows Debbie Bidell and Tracy Morris, for example, have developed a peer pairing approach where they get volunteers from the community, from schools and stuff, of children, and these are children 8 to 12 years of age, to participate in play activities with other children. And they're not telling the kids that the other children have social anxiety, but they take them bowling, they take them to parks, they do different things. And that kind of, and they're instructed to demonstrate good friendship behaviors. So that model has very good support behind it. It's been extended in adolescents. There's also mentoring programs that have been developed, and there's good research behind it, for college-age students to mentor and be buddies to young adults with Asperger's, for example, and developmental issues. So, and there's a psychologist over in Israel who has done a lot with this. So there's all different kinds of programs built on this mentoring model, yeah. And it's capitalizing on the modeling aspect and also the context of, again, being with someone who's a little more similar to you, age-wise and social life-wise, so that it's more reinforcing to the person. So in this case, rehearsal helps, and we repeat activities for kids when we're doing peer pairing and modeling and things like that, because we want them to remember what's being observed, we practice with them, and that's why we assign homework. Or, in CBT, we send them home to practice what they've learned during the week, and we use pretty much a 3-time rule. 3 times in 7 days is the minimum to practice what we send you home doing. The patient has to be able to replicate the behavior, so we want it to be developmentally appropriate and on target, and we don't want to give them something they can't do that develops into frustration and they give up. And there needs to be motivation. And the motivation may come in different ways with using incentives, if they're younger children, sticker charts and things like that, or using, trying to build up some motivational enhancement techniques. This is, something that's used especially in the area of substance abuse, motivational interviewing, and for other problems like that, when the patients have low levels of motivation to change a behavior that's particularly upsetting or destructive. They're using it more widely now across the board in therapies. The rationale for CBT, we're looking at the multidimensional nature of any issue in terms of an emotion and a feeling. There's a physical aspect to it, and so we may apply relaxation techniques, deep breathing, mindfulness meditation to deal with increased activation of the nervous system when it gets out of control for someone. There's the cognitive elements of this, where we're going to apply cognitive restructuring to parents. I want to kill this kid, as well as to the child. Yay, I got an Xbox. So we're going to work with that. And then there's the behavioral aspect, rule breaking, tantrums, hitting, spanking, harsh discipline, things like that. We've got to work with everybody there on changing some of the behavioral strategies that they have that have not been effective. Some questions that are basic to working with children from a CBT perspective. What's maintaining this problem? So what have you tried to do? How long has any of that worked? And to what extent? But what's going on that's keeping it there? All right, so we really need to look at what the maintaining factors and variables are. What are the child's weaknesses and strengths in coping? How many routinely ask parents what their child's strengths were? How many parents come up with them like that? Because they are so focused and overwhelmed by the weaknesses and the deficits or the behavioral excesses. So we need to focus parents on strengths. And I find the littlest thing, even if it's doodling. I had his artwork. He calls it his artwork. He's doodling in his book all the time. Let me see those doodles. Let me see what they look like. Oh my gosh, do you ever take a look at these? Wow. So working whichever way you can to help refocus some of that. And then what role are the parents playing in being involved in the problem and maintaining it? We're not blaming you, Mom. We're not putting it on you, Dad. But what role how have you been swept in and now you're part of maintaining this? Because we do have to get you to change some things in order to affect a change in your child. Here's another New York. When I moved back to New York City, to Manhattan in '98, this was classic. I'd been working in Albany. I had worked in Kentucky. Parents come in with their children. We do all our stuff fine. Very first case assigned to me in Manhattan. The child was 8 years old, had ADHD. The child had been in therapy since 4. In Manhattan, once you find out you're pregnant, you get on the list for the preschool and for the therapist. Okay? You didn't see this in Real Housewives of New York City? So anyhow, here I am on the phone with this mom, and she tells me, describes her child, fine. I said, okay, we agree, 5 o'clock on Monday, I will see him. And her parting comment to me was, make sure when you're done, you walk him out to the driver. Oh, stop. I had never met this person. But the culture and everything that was going on there was, for this particular family, there were nannies involved and drivers and this and that. But the culture was dry cleaning. You drop it off, the kid gets cleaned and packaged, and then you send it home. It's like, no, we're getting you, and I want you and the dad here. Maybe I didn't make that clear. And so that's very important because there's something going on in the system. The whole system has to be involved. with helping to change the child. All right? And we have models where we involve siblings that we can talk about as we move along, too. The behavioral analysis is that understanding what's maintaining the child's existing behaviors is important because then that helps us to assign and develop the appropriate methods to change the behaviors. And this applies to parenting, to in-session work, school behaviors, individual child therapy, all the way along. We want to do a behavioral analysis or functional analysis, a case conceptualization, and the case conceptualization helps us dictate where we're going in terms of the procedures and the approach we're going to be taking with the family. So just some more basics. Reinforcement is going to strengthen a behavior. The reinforcer must be contingent on the behavior being performed, not given the night before the behavior is performed. And, we get a lot of biases. I'm not going to give my kid something to do, something he's supposed to already know how to do. Okay. Reinforcers accelerate behaviors. Rewards, on the other hand, which is what parents are looking at. Why am I going to bribe and reward them for something? Rewards actually don't, they're not necessarily going to shape a long-standing behavior. They're going to reward you in the moment for doing something, such as gobbling down pies, or it's that time of year in New York where the Coney Island hot dog eating contest is going to come up soon, and whoever wins is going to get a reward, although I can't imagine that the days afterwards they're feeling too good about it. But, rewards are one-time things. That's not what we're looking for. We're looking to shape behaviors with reinforcers. Parents really have to understand positive reinforcement. And here's another thing. Positive reinforcement is presented as a consequence of a response. You can use tangibles, stickers, star charts, things like that. You could use activities. Activities are really valuable to kids, especially kids who don't get a lot of activities or are overextended and overscheduled. But activities, free time, recess time at school, playing a game. Social reinforcers within activities, spending special time with someone they want to spend it with. It's very important. Token reinforcements are, again, stickers or points. And feedback. One of the things I teach parents to do with their children is as the child, let's say you want the child to do their homework. That's part of the issue is she doesn't sit down and do her homework and he's always around. Well, I'd set it up, where they have a table or where the child is going to be working on the homework. And what I teach the parent to do is just simply this. Just simply acknowledge to the child that you are happy they are sitting there and working like that. That is feedback in just a very simple way that doesn't take any real effort on anyone's part. The child's got your attention and they're so happy and they keep going because of that. Very simple little thing. Also, the thing with reinforcement, getting on here, another family, 4-year-old daughter. Dad was a businessman who was gone a lot. And so mom had the child sleeping in bed with her while dad was gone, which resulted in the child sleeping in bed with her while dad was home. Well, they were still young enough parents that dad didn't like the fact that he didn't have access to mom and their relationship anymore. So anyway, in my office, she wants this child to go back into her. They want the child to go back into bed. In my office, the father who's frustrated just says, look, if you sleep in your bed, I will get you the Barbie outdoor playhouse thingy that, this construction thing that they would put up in the backyard. I'm like, what in the world? I'm like, whoa. And the little kid is like, oh, yeah, I'll sleep in my bed, Daddy. Ah. And I'm like, yeah, right, fella, for the weekend, maybe. So I said, wait. Now, and this was actually in July. I said, wait a minute. And I took out a calendar that I keep, and I said, let's look, this July, August, September, October, all the way to Christmas. I said, how about on Christmas, we put a picture of the Barbie house. And if you get a sticker every night get it at Christmas time. The father's looking at me like, yeah, right, lady. The kid's like, yes. And I pulled out my drawer of stickers. What's the stickers that you want? She picked out the stickers. Okay, and off they go. Do you know, a couple of weeks later, the child comes in and walks right into my office and says, Dr. Albano, Daddy's away, and Mommy wanted me to sleep with her, but I said no because I want my stickers. All right? Showing the parents, hey, you do not have to buy the big stuff. Kids will work for very, small things, little token things. So it was, it works, but you've got to apply it and you've got to work with the child on it. Social reinforcers, these are among the most natural reinforcers and the most powerful, right? Which is why bullying is so horrible, because it's quite the opposite of what we're looking at here, real punishment. And then we get into the issue of negative reinforcement, which we don't often use as a therapy procedure per se, but it's taking a stimulus away, and that increases the likelihood of a behavior. But Tamar Chansky, who's a psychologist and has some very good books for parents, has an illustration in one of her books she published back in 2004. The example of tantrums and how negative reinforcement works. And so here you see in the first curve, the child is giving a tantrum, and at the height of the tantrum, where the parent has pulled out half of their hair already, and they can't take it anymore, they're like, fine, you can stay home from school. Okay? At that moment, what happens is that's solidified in the child's mind. The height of that tantrum, all I have to do is go from 0 to 80, and I'm home. They know what to throw in terms of the nuclear level of that tantrum to get what they want. It prevents the learning of a positive experience of calming themselves down. The tantrum is reinforced. The parent, has given up, but get ready, Mom, you're going to do this again tomorrow. However, if the parent follows a program of ignoring the tantrum, and in cases of school refusers, we'll be like, okay, I'm going to put the clothes that you're going to wear in this bag so you could change in the car. But I'm leaving with you in 5 minutes. And just moves along very calmly without paying attention to the tantrum. The child will go along crying, complaining. They'll moan and groan the whole way to school. But they're going to remember, as the parent pays attention to them at the times when they're quiet or more calm, and the parent starts talking to them, they're going to remember that calm behavior is reinforced, and that tantrum will not be rewarded. So the appropriate behavior is shaped. All right? So we've got to keep an eye on this, because this is a big thing parents don't get. They fall into what Rex Forehand has called the reinforcement trap, and what Patterson called the coercive process. The parent, Michael, please clean up your room. Mike, I don't want to. I don't want to. No, I don't want to. It gets louder and louder. Michael's crying, Michael's screaming, Michael's kicking. It goes on, and the parent says, fine. But next time, you do this when I tell you. All right? The outcome is Michael's behavior, his inappropriate behavior, is reinforced because his parent gave in and withdrew the request. His negative state of, oh my gosh, I have to clean up my room, and throwing that tantrum was totally reinforced for the next time. Here's another one. I really mean it this time. Pick up your room. Michael, no! And he's spitting now, and he's kicking, and he's biting, and parent, that's it, mister. I've had it with you. She grabs and shakes the kid. And the kid all of a sudden, whoa, uh-oh. At this point, the child slinks off, and he cleans up his room. But what is he reacting to? Fear, the threat. The child complies with the parent's angry behavior, and this reinforces, right, his fear of her. The parent, though, is reinforced here for acting so angry. So we have to be very careful with what negative reinforcement does. Works on both parties. Shaping is very important, and this is the thing. Break down these behaviors for the parents and help them learn how to shape them in their children with smaller steps. Now, I'll get back to my father, who called me while I was on my day trip with my niece and nephew at Ellis Island, right? So here they are, they're supposed to go to grandma's house for something. The kid has been on that gosh darn Xbox. It's 10 o'clock already. He's been on since 5 a.m. The father is on the phone. He's all upset. He's got the wife on. I said, listen, hold on a second. Carmine, it's not his name, but Carmine, hold on a second. I said, let me ask you a question. I said, when you were a kid, on Sundays, did you used to go to your Nana's house for macaroni? Yeah, every week, of course. Okay, let me ask you this. When you walked into the house, did your grandma hand you a cannoli or a plate of pasta? Hey, first you eat your pasta, then you get your cannoli. Oh, he says, oh my God. I said, yeah, hello. I said, take that Xbox away. Unplug it and put it away. And you say to your child, if you get ready to go to grandma's and we go and you behave at grandma's, when you come home, you get 10 minutes of Xbox. Oh, you're brilliant, you're brilliant. I'm like, I'm not brilliant. The Premack principle is grandma's rule, Nana's rule, La Abuela's rule, whoever's rule. It's grandma's rule. First you eat your spinach, then you get your ice cream. And this is what parents have to learn. You don't bribe by giving them something and saying, do it, then you say, okay, do this, and then we're gonna have that, all right? Number one thing to teach parents, very important. And that reinforcement has to be contingent and consistent. You could start out continuous and then you break it down to intermittent, where it happens every once in a while, but it has to be potent. Another thing that parents like go nuts when I keep little Dixie cups. I mean, they're like, you know those little tiny, those Dixie cups? I keep those in my office. And for kids who won't stay in bed all night, here's the deal. I make a deal with the child. You stay in your own bed, you get up in the morning, you get ready for school and eat your breakfast, and that's when I pull the Dixie cup out. What do you want in the Dixie cup that your mother and father don't let you have? Oh, Fruity Pebbles, ice cream. What the heck? Give it to them. It's a Dixie cup filled. They will stay in their bed all night. But remember, they got to get dressed and eat their breakfast first. And that's just a little token reinforcer that's potent to the kids. I have a friend who has a website. She wrote about this, using it with her child. His thing was bacon dripped in raspberry sorbet. That's in his Dixie cup. So anyway, make it so that the child feels excited about it. Extinction, behaviors are maintained by reinforcement, so when the reinforcer is no longer available, the child stops engaging in the behavior. And this is the biggest thing for parents. Now look, when the child is born, the most deepest sleeper in the world, the person who was a college student and lived in a sorority or fraternity that, John Belushi was throwing a party at, they slept through all that, all kinds of noise, they could sleep through everything. But the moment the baby is born and the baby in the other room goes, in the middle of the night, then parents awake.
That's true.
Right? Very true. Parents wake, whoop. Okay. But what happens over time is that parents, the moment they hear a oh out of a 5-year-old or a 7-year-old or a 10-year-old, they react. It's no longer reacting with, what's wrong, honey? Now it's, They react immediately to those whines. So what we have to teach parents to do in terms of the extinction approach is don't react at the whining. Let it happen. They'll be on a reality show one day and make a lot of money. Leave them alone. Leave the whining alone. All right? Whining, crying, and small tantrums, we let go and teach the parents to walk away from. Ignore, we want them to have no physical contact during the process of ignoring a child. Don't speak to them. No eye contact. You're really removing yourself as a social reinforcer to the child. And keep at it. It will decrease the whining, decrease the crying, the attention demands and such. So ignoring is very important. And this is where, when I work with parents and colleagues who do this, with parents of children with externalizing disorders, we teach them parent mindfulness meditation strategies. Go back to that comfortable room you had in college, surrounded by your favorite stuff, with the refrigerator next to the bed that had your chunky monkey in it. You were so happy, you had no care in the world. Go back to that place, be in that place, to steel yourself and take deep breaths and let go of the tension that you're hearing around you. In fact, it fades away. I do a lot of work and practice with this with parents. We have to warn parents it gets worse before it gets better. That is the extinction burst. Go into a casino. Walk through the area where they have the slot machines. And what will happen is you see this. Like if you pull it faster, it's going to make money come out. That's the extinction burst, because they're not getting paid off. They're going harder and harder at it. And that'll happen, so get the parents ready. It's going to happen for a little bit. Keep ignoring, and this brief increase is going to die down to nothing. The other thing is, the child's in their bed, the child's in their bed, the child's in their bed, no problem. And 3 months down the line, you get a call, oh my God, we're back to square one, because the child came into the bed. But the question here is, what's going on right now? This is just a little spontaneous recovery of the old behavior. Maybe the child wasn't feeling well, maybe there was a thunderstorm, whatever it might have been. But what parents tend not to do is follow the plan. Just pick them back up and bring them back into the bed, all right, their own. They give in to it. So we have to remind them, are you back to square one, or is it there was a little blip and we've got to get back on the program? And the thing that I like to use is the diet analogy. New Year's Day, everybody has that resolution. This is the year, I'm going to do it. I'm going to lose 25 pounds. And they go through the refrigerator and throw everything out that has a calorie in it. They get rid of all this stuff in the icebox, and everything's gone. And this in New York works better than here in Florida, because then what happens is you go to the gym every day, and you're going, and about a week and a half, you're feeling great. We suddenly have a nor'easter snowstorm. The city stops. You're stuck indoors. And it's Lifetime for Women TV. All day long. And round about 4 in the afternoon, when you've seen how many women who murdered their husbands and this and that, you go hunting into the refrigerator. And in the back of the icebox, all freezer burned, there is a chunky monkey. And you take that chunky monkey and you're like, oh my God. And in your mind, what do you say to yourself? That's it, I'm back to square one, I blew it. It's over. Next day, the plows come out, the roads are clear, but you're not going to no gym. You go to the grocery store. No. You know, this is the thing to any kind of successful behavioral plan, is recognizing there will be a slip. Get back on the program. And when I explain it to parents with that diet analogy, boy, there's not one of us who doesn't relate to that one, right? They get it, all right? And they understand we got to get back and help the child get back. What's getting in the way of sticking to the program? Let's figure it out. There may be a new baby in the house. There could be a change of some sort. Let's deal with it and get back on it. Timeouts. We know this is taking children out of the situation, not putting them in their room to play. And again, I recommend Super Nanny for some parents to watch, and how she uses some of these timeouts. If you don't have examples of them yourself on tape, and then the other thing is you could practice them with the parent and the child in your office. So minimum of 1 minute per year of the child's age is what we use for a timeout, with a top off of about 5 minutes for the older kids. Teenagers respond to removing something, a privilege, or children loss of points. These are some other ways of shaping behavior. Overcorrection, that I call the Dominican nun technique. Remember when, I don't know, those of you like me, I had 12 years of Catholic high school, writing on the board, I will not throw spitballs. I will not throw spitballs. So write it 100 times. You don't want to throw spitballs after that for at least a week, right? But overcorrection, correcting the effects of an action by intensively practicing them. We don't tend to use that much. More along the lines of contingency contracts are the way that we go. Making a very well-defined, easy, simple contract between a parent and a child or teenager. The target behavior has to be unambiguously specified. The consequences of performing it or failing to perform it are clearly stated. If John stays in his seat for the morning session, he gets to feed the class fish. Very easy stuff. This actually was used on my nephew, one of my nephews, not the cute little one you saw here, but another one, where he was having trouble riding the school bus, and my sister set it up with the principal. If he rode the school bus, he got to go into the principal's office and feed the principal's fish, right? Kindergarten kid, it just turned it around very quickly. If Mary puts her toys away when asked, she gets an extra 15 minutes of computer time. Contracts, though, have to be very simple. I had a father and a 14-year-old daughter I worked with, and the dad happens to be a high-powered attorney in New York City. I got a 10-page document sent to me that was the contract he wrote up. I'm like, no. Very simple. If you do this, then you get that. So we'll talk more about parents, and parents will be talked about, I think, in any of the workshops that are going on, but how they get involved in these negative interactions, the coercive process that occurs of building up affect. We want to teach them contingency management and also examine the maintaining variables in the way that they're involved. We want our parents to be consultants to the treatment, cheerleaders to the kids, providing encouragement. We want them to be coaches to their children, supervising and administering different treatment components, and sometimes they're clients, because they too may be the subject or target of specific interventions. So they have to understand that, and they're a part of their child's therapy. The thing to watch for with CBT in training many people over the years who have been trained in different approaches and then come to CBT is when they get stuck, they abandon ship. This isn't a CBT issue. This isn't a patient that needs CBT. Aaron Beck, the infamous Dr. Aaron T. Beck, in doing a training with him a number of years back, he really said, you have to have the identity and hold the formulation all the way through. Because it's interesting, when I work at Columbia, we have a community clinic that I supervise the residents and the interns in, and sometimes they'll come and they'll say, oh, there's no cases assigned to me this week. There weren't any CBT cases. Whoa! Anyone is a CBT case, in that it's holding this formulation, being consistent with the patient as opposed to giving them inconsistent messages if you get stuck. So don't abandon ship, stay with the program, and go the whole route. Don't just do watered down CBT, because then your patients might get confused. Yes?
Could you repeat that quote? You have to have the identity.
Well, it's Aaron Beck who talks about identifying as a cognitive therapist. To me, it's cognitive behavioral, where it's your frame. It's the way that you interact with the world, as well as understanding the way that you are transmitting information to your patients and working with your patients. I tend to see the world in terms of relationships and reciprocal relationships and shaping that's going on. Didn't Donald Trump do a good job of shaping Obama this week? Okay, so, the world is all about what's being shaped, what's being responded to. So I hold the frame that way. I'm not going to go into the deep psychoanalytic processes behind either of their personalities. I will leave that to the pundits. So we will take a break here. Thank you for being a part of this basics workshop, and we'll reconvene in about 15 minutes.